Good morning, everyone. Thank you to our resident humorist for enlightening us today and starting our day off very nicely. This morning, we are going to spend some time getting a 101 on Medicaid. And the reason that we're doing that is because every department that we deal with, and particularly the Department of Disabilities, Aging and Independent Living, it has a large amount of Medicaid that funds the services. And honestly, Vermont could not do what it does. And even though we all, have some opinions about whether it's enough or not enough in some places, in some ways, we couldn't do what we do without the assistance of federal funds through the Medicaid program. So it serves everyone from very young children and families and VCF to older Vermonters and people at end of life who get supports through Dale and everybody in between. And so we've asked Nolan Langwell from the Joint Fiscal Office and Ashley Berliner, who will be here shortly from the agency. She's in the waiting room?
She is now.
She is now. So who will be here momentarily. So why don't we wait just for a second for her to come in? Because we've done introductions with you, Nolan, but we haven't with Ashley. So let's wait for her to join.
There.
There she is. Ashley, we're just waiting to see your face. There we go. Good morning. Good morning. Welcome and thank you for being here. We were just because you haven't been in our room yet this year, so we were going to do a round of introductions so that you know who you're speaking with and what part of the state they're from. So my name is Teresa Wood. I'm from Waterbury and I also serve Bolton, Butte, Euless, and Huntington. The right hand side.
Ann Donahue from Northfield, also serving Berlin.
Good morning, Dan Noyes. I represent Johnson, Belvedere, Hyde Park, and Wolcott.
Doug Bishop, representing Colchester's Chittenden 20 district.
Brenda Steady, East Milton, Westford.
Then over here, I'm Zon Eastis and I serve Guilford and Vernon.
I'm Esme Cole and I'm representing White River Junction, Hartford, Vermont.
I'm Jubilee McGill. I represent Bridport, Middlebury, New Haven, and Weybridge.
Hi, I'm Ray Garofano, Essex and Essex Junction.
And we'll go around the room and then we'll get to the screen. Lori. Yeah, just a second, Todd. I'll go.
Lori Morse, Committee Assistant. I am Mike Polite from the Alzheimer's Association of Vermont chapter.
Alex McCracken, Department of Vermont Health.
Okay, and Representative Nielsen, go ahead if you can speak.
I speak kind of. Todd Nielsen, I represent Brandon and Forestdale, and thank you.
Great. And we'll turn it over to Ashley and to Nolan. And I think we have a presentation on our website as well, if you want to follow along there. And I don't know if one of you wants to share your screen. That would be great too.
Great. For the record, Nolan Langwell, the Joint Fiscal Office.
Berliner, Director of Medicaid Policy for the Agency of Human Services.
Now I'm going to share my screen. All right. So we're going to tag team a little bit. The goal here is to give you a very high level Medicaid overview. The sort of joke that I always start off with is that Medicaid is very, very complicated. And if you don't get it the first time, don't take it personally. It's not you. If you don't get it the second time, it's still not you because it's stuff really complicated. However, if you don't get the third time, it's still not you. I mean, this stuff is, that was, we didn't want to ruin that joke earlier, but
it wasn't as funny as some of your other ones. I'm sorry.
It's all the delivery. But my point is that this stuff is really complicated and it gets complicated fast. So we're going to start on the high level about who's covered, what's covered. Then we'll start working our way into things, concepts like FMAP and global commitment, which start getting a little weedy. So my first thing I kind of have to do is my disclaimer. So throughout the presentation, I'm going to have lots of numbers and charts. Some of them are quite outdated. Part of it is because two of the sources I used mostly for this, one is the Vermont Household Health Insurance Survey, and the other one is the Vermont Expenditure Analysis. The Household Insurance Survey hasn't been done since I think 2021. It is actually being done this year. So we'll have new numbers next year. That's one that gets done every 2 to 5 years. So we don't know how many uninsured there are, but we currently, and we don't have any post-pandemic. We just have mostly pre-pandemic data. The second is the expenditure analysis, and the Green Mountain Care Board puts this out every year. There's a bit of a 2-year lag on it, but they haven't put it out in a couple of years, and that's because of some personnel and some vendor issues that they're working through. We hope to remedy soon. So I have to disclaim that when I have up-to-date data, like from DEVA, for instance, that's only several months old, I will point that out. So that's my disclaimer. So we're going to start it from the context of, we're going to start with some context, move into what is Medicaid, start getting the Medicaid finance, and then move into global commitment. Again, this is one that starts a little bit old, but it hasn't really changed. And this gives you a sense of how many people are covered and under what particular health insurance plan. So you can see 49% of Vermonters have private health insurance, and the majority of that is actually employer-sponsored health insurance. 24% are Medicaid and 21% are Medicare. We're going to be talking about that 24%. The number may have gone up or down since then, but it's going to be in that same quarter of Vermonters ballpark. And this is as a source of primary health insurance. I throw this in, this is a little bit dated too, but again, I don't think this has changed much. The concept here is government versus private coverage. Government in this case is Medicare and Medicaid, and private is commercial. And so you can see in 2008, 60% of Vermonters had private insurance, and then 30% had Medicare or Medicaid, Medicare being that top 14%. But then you fast forward to 2021, and you can see that 60 has gone down to 49%, and the 30% has moved to 45%. So you can see over time, less people are under private and more people are under this government insurance. And Medicare and Medicaid have both increased over that time. Now, one would make that the jump to the assumption that all those people are switching. And that may be the case, but it may not be the case. There might be other factors involved. We don't know what that is, but the point is that there has been a shift, and I just wanted to highlight that. I'm looking forward to seeing what that shift will be going forward.
Representative Garofano.
Thank you, Nolan. The government percentage, that does not include the Affordable Care Act, like the exchange.
Great question. That does not. Well, yes and no. It includes the Medicaid people. So we have a Medicaid expansion if they were unaffordable. But the people that are receiving a subsidy through the health exchange, that is not because their primary is private health insurance, but they're getting some form of, and actually I get into this in my next slide. So, no, I don't. All right. So, but yes, those people that are getting subsidies in exchange are under the bucket of private health insurance, but they're getting subsidy through Department of Vermont Health. Good question.
And those subsidies end when?
I forget. So there's two. So their subsidies don't go away. The expansion of the subsidies, they were up to 400% under the Affordable Care Act, and then under one of the COVID bills, it went out further. Maybe Ashley knows the answer to this, and I forget. It might be at the end of 25 or 26 that expires, but it will go back to the regular 400%. So they don't go completely away. I don't know if Ashley or Alex know the answer to that.
I'm just a Medicaid person, unfortunately. I can't answer qualified health plan questions, but we can definitely follow up.
Okay.
End of this year, 2025.
Yeah.
Yeah, I can say that for the record, Alex McCracken, Department of Vermont Health Access, what you've outlined is more or less correct. The 400% subsidies are in the ACA and they will remain. But what goes out further than that, which amounts to around $65 million in subsidies that we apply to develop the stock marketplace, would expire at the end of this year without government.
And to change that would take an act of Congress. which
Do we know how many people how many Vermonters take advantage of that?
Around 30,000, I believe, so.
it's around,
Otherwise, health insurance is unaffordable for them. Mhm.
yeah, last time I looked, it was around, yeah, so,
Okay,
I
thank
can
you.
get you an exact number, but I think the range is 26.
Yeah, I was looking for a magnitude, so,
yeah, it's 27 to 30. I have a pretty different presentation. But
all right, thank
this
you.
is-
Sorry to
No, no.
sideline you there.
So what is Medicaid? First thing I'd like to do is the difference between Medicaid and Medicare. They are not the same. People often conflate them or even misspeak. I will probably refer to Medicaid as Medicare at some point in this presentation because it's like, no, they're so close. But then I always correct myself. Like it's like saying when you're naming your kid like Johnny Steve, what is your name, boy? Like it's the same kind of thing. One mnemonic device that some of the other committees have used is like, oh, Medicare stands for, Medicare has an E and E is for elderly or, people use different, but they are very different. So the difference is Medicaid, which is what we're here to talk about, is a state federal program. Well, Medicare is just federal. We don't have any influence or control or any kind of oversight over Medicare. It's purely federal. Where Medicaid is a state federal partnership, and we'll get more into that in a minute. Medicaid eligibility is for low income, for children and adults and 65 or older, blind and disabled. Medicare is all income, so it's not income based. It's 65 or older, or anyone with any age with end stage renal disease, and then certain children or certain disabilities for those under 65 will also be on Medicare. So again, Medicare, all federal, Medicaid, state and federal. So Medicaid was created in 1965. It's a public health benefit program for low-income individuals and families and individuals with disabilities. As I mentioned, it's financed through a federal-state partnership and administered by the states. Each state designs and operates its own program within the broad federal guidelines. So the joke within Medicaid, among Medicaid people in the Medicaid world is, if you've seen one Medicaid program, well, then you've seen one Medicaid program. And as I go through the program, the presentation, you'll start to see what I mean by that. And you'll actually start laughing at that joke.
Pretty loud.
So this actually goes to Rep. Garofano's question. So nationwide, approximately 80 million people have a Medicaid or CHIP. Now, CHIP is technically not part of Medicaid, but it's a separate program. However, in Vermont, we administer CHIP as part of our Dr. Dinosaur program, which is part of our Medicaid program. So in short, Medicaid administers our CHIP program. And so for our types of budget purposes, we count them. So approximately 197 Vermonters receive some form of assistance through Medicaid and CHIP. Now, this gets to that primary versus partial coverage. We have 197,000 people who have who are covered by Medicaid, so that's about a third of Vermonters. However, and this is a thing that if you're talking to the media, I often clarify, in terms of Vermonters as a primary source, so people who are actually on Medicaid, Medicaid is their primary source. That's about 23% of 151,000 Vermonters. And then you have another 46,000 that have some form of assistance. So that would be the exchange subsidies. That would also be folks who are on BFARM. And BFARM is a Medicare wrap. It helps seniors, low-income seniors, pay for their Part D drugs, et cetera. So another 46,000 have some form of relationship. So again, a third of Vermonters work or have some relationship with Medicaid, but only a quarter of Vermonters are technically on Medicaid as the primary. I'm going to pass this over to Ashley.
Nolan. So in Medicaid, in order to qualify, you have to be a resident of the state that is administering the Medicaid program. So for us, you have to be a Vermont resident. You have to be a U.S. citizen, permanent resident, or a non-citizen with lawful presence. There is a strict prohibition against providing Medicaid coverage to anyone who is not residing in the United States legally. For anyone on the Medicaid program, you are characterized financially as having low income or very low income. And it used to be, prior to the Affordable Care Act, that in addition to having low income, you also had to fit into a certain category. So you used to have to be pregnant, a parent, caretaker, blind, have a disability, or be aged with that very low income over 65. It was the Affordable Care Act in 2014 that allowed coverage for what we term the new adult group, which for the first time allowed Medicaid to be delivered to individuals at a low income who didn't fall into that category. So single adults that did not have children, for example. This is what people mean when they talk about state Medicaid expansion. They're specifically talking about that new adult group. In terms of coverage, Medicaid is a comprehensive insurance package. It is required to cover mandatory benefits per the Social Security Act. And there is also a menu of optional benefits that can be covered at state discretion. This chart reflects that. In the purple is mandatory services. These are all of the services that every state in the country must cover under their Medicaid program. And then the optional services vary state to state. You'll note some unusual services for optional services that you would assume would be mandatory, like prescription drug coverage, for example. That is technically not a mandatory service in the Medicaid program, but every state in the country does provide it. In Vermont, we have adopted all of the optional services under our Medicaid program. So this entire list is covered through Vermont Medicaid.
So this goes back to, if you've seen one Medicaid program, you've seen one Medicaid program, because not everybody covers all the services.
So what would, excuse me, just a second. I think one of the things that always strikes me when I think about mandatory and optional and think about each state,
You're awesome.
think about, it might not be. Your question, we'll see, is when we think about long-term care services, for instance, that we provide under global commitment and were previously provided under a 1915C waiver. Those are all optional services. They're not mandatory. And so things like residential services for people with developmental disabilities, people who cannot live on their own without assistance, personal care services for older Vermonters, things, assistance with activities of daily living. Those are all optional. And it's sort of like odd that really on the federal scene, they haven't really moved to something that's more in line with what I think that the vast majority of states actually do cover. So as things being mandatory, and kind of funny that there hasn't been any legal action thinking about that. I'm just thinking about that.
To your point, prescription drugs and dental.
Yeah, I know. Well, in dental, only dental for adults or only dental for children?
Is it? I thought it was this.
Adults is an optional service.
It's an optional, yeah. Yeah.
And your point
We didn't
about
used to cover. We
long-term-
didn't used to cover dental for adults, but I'm glad we do now.
Yes, we do. We have a limited dental benefit. But your point about long-term care is a really good one, which is mandatory nursing facility services are covered under Medicaid, but all of what we think of as lower cost, better quality of life for our members, those are considered optional, which, you know, it's an interesting policy decision from Congress that they haven't changed that.
Yeah. Thank you. Did you have something else, Representative Steady?
I don't know. It says mandatory services. I just don't understand.
It means that a state has to provide them.
That's what it means. Okay. So.
And in this case, we provide all of these things that are on this page.
I knew they said the optional, so mandatory here means they have to cover it.
Yeah.
Okay.
Every state has to cover that.
Okay.
If you participate in the Medicaid program.
Right.
And by the way, the mandatory services are also the big ticket monetary ones as well.
Long-term care is pretty big ticket.
Sure.
Oh, that's, we know that.
Yeah.
So we're gonna move into finance. So just again, some context, again, this number is old, but in 2020, Vermonters spent 6.4 billion on healthcare. I suspect that if I had that number for today, it would be about 8 billion.
It would be a lot.
And that's across everything. That's Medicare, Medicaid, private insurance, you name it. It's like just across the system. We're only talking about Medicaid. Medicaid accounted for 27% of Vermonters' healthcare spending. That number probably hasn't changed. It's probably still about a quarter, right? This has state implications. So this is the state budget. There's a chart of the state budget from 2024. And in 24, Medicaid accounted for 27% of the total Vermont state budget. So again, we had an $8.7 billion budget in 2024. Medicaid was 2.3 billion of it. And I just sort of threw in the little line off the human services just to get a sense of how much of the human services budget alone is Medicaid. And then you can compare it to the second largest, which is K-12.
Go ahead, Brooks.
I have a question, and it's probably again, the computer system, the tools that you're giving. How come 2020? I mean, we're in 2025 now. How come the stats are from 2020?
I said that in my disclaimer in the beginning is that.
I missed it.
Oh, okay. That we just don't have the data. There was and for that would be information from the Green Mountain Care Board under their expenditure analysis. And they haven't been able to release a report because of some personnel changes and then some vendor issues. So they're working to remedy that. But I said that early on in my first
I
disclaimer
must have just
was
missed
like,
it.
hey, these numbers are old. I will point them out that
Wow,
they're
but,
old.
you know, that's like way old. I mean,
Well, I mean, these ones though, I want to point out are 24, FY
so
24.
these
This is
are,
24.
okay, so
But the
these
other
are
chart,
good.
That's what it says, FY 24 right there.
but to the
Okay.
point before that, this is from 20, so I think it's probably 8 billion today, but in terms of the percentage, it's probably the same. You know, percentage of spending as Medicaid, it's still probably in that quarter, give or take 2%.
So how did they get these figures without the other figures? Is
These
it
are our
part of
state
the
budget.
thing?
This is our state budget.
This is just our.
We know how
state
much we
budget?
spend in the state, in our state budget. We appropriate, you will vote
okay.
on this.
Okay, so this, okay, now I get it, why,
Yeah, yeah.
okay.
Representative Garofano?
Thanks, Nolan. The 27% of the total state budget, how does that compare to other states? Do you know?
I don't. I don't. I suspect it ranges. You know, you have some states that have very minimal Medicaid budgets. Then you have states that have very generous Medicaid budgets. And then you have some states that have different socioeconomic, right? So I don't know the answer to that. I don't think I've.
You do have coverage for Medicaid.
Sorry, Ashley, can you say that again?
High end of coverage for Medicaid. A lot of states are around like 22%. There are some at our same level, but we're definitely on the higher end.
Thank you. So again, our total budget state appropriation for 24 was 8.7 billion. And again, not to confuse us with spending on healthcare, it just happens to be close, it's a similar number, but we're talking about the state budget now. And you can see that, so as I mentioned, 27% of, this is just a visual of the 27% of our total state budget. Now, Vermont gets a lot of federal money. We get about $3.17 billion in federal dollars. So that's 36% of our total state budget. But 40% of our federal dollars are for Medicaid. Again, this is just meant to give you some context of how big Medicaid is and what role federal funding plays. So our overall 24 Medicaid expenditures of 2.3 billion. Medicaid, as I discussed earlier, is funded through a combination of both state and federal matching dollars. There's this thing we call it, it's called FMAP. It stands for the Federal Medical Assistance Percentage. This is the majority of our federal dollars in the Medicaid is through FMAP. Some of it's through other funds, that might be grants or some other type of things, but most of it's through this FMAP. Most, but not all of our federal funds are FMAPs, as I said. Then we have multiple FMAPs. We have, and they can range from 50% to 90%. But our overall average participation is about 62% of federal dollars. Now, this doesn't chart for that, but so how is FMAP calculated? How does every state has a different FMAP? And it basically it's a share of the state's Medicaid benefit cost. Sorry, I'm here. So FMAP is basically calculated based on a 3-year average of state per capita personal income compared to the national average. No state can receive less than 50% or more than 83%. So there's a bottom and a top, but in between there, different states have different FMAPs. Now, the states that have the higher per capita income, those are your Californias, your New Jersey, your New Yorks, they're sort of bottomed out at 50%. So they're 50-50 state match. But then you have states like Mississippi and West Virginia that have a much lower per capita income, and they're getting matched around 77%, 75%. Our current regular FMAP is 59% for our regular FMAP, but we also have what's known as enhanced FMAPs. So these are some of our different FMAP rates. So our regular FMAP, and this is what the majority of our programs are this 58.81 federal, 41.2% state. So translated, for every $1 we spend on Medicaid, we get $1.43 in federal match for a gross total of $2.43. So in short, $1 of state funds buys $2.43 in services. Now, it goes both ways. For those of you that were here 10 years ago, and they were looking, and we had deficits, and they were looking at budget cuts. If you cut $1 from the Medicaid budget, you lose $2.43 in services. So it cuts both ways. The CHIP program, which I mentioned earlier, is around a 70-30 match. That's about 4,000 kids that we get a 70-30 match on. And then we have this new group called childless new adults. Now, they're not new adults. They're a new category. But this was that Medicaid expansion under the Affordable Care Act. Now, a lot of those people in Vermont were either covering Catamount or VHAP or some other program. And so there was sort of like a shaking of the snow globe. But for this particular group, we are getting a 90-10 match. And we will continue to get a 90-10 match in perpetuity. What I mean by that is until Congress changes that. Now, why is it so high? Well, when the Affordable Care Act passed and states were forced to expand, there were a lot of states that did not cover, had very vague, did not have as generous coverage as we did. And so the federal government, for a short period of time, paid for those folks 100%. And then slowly over, I think, a 6-year period, worked its way down to 90-10. And then for the states like us that were already doing stuff, we were like, hey, that's not fair. So they gave us 80-20, and then we worked our way to 90-10. So everybody sort of grew together. And it will stay that way. And that's about 41,000 people that we get this match. These are childless adults.
Noise.
That's for healthcare coverage, correct?
For Medicaid.
For Medicaid.
Yeah, you're, go ahead and ask the question that I'm thinking of.
Yeah, like for youth exiting foster care for programs for them, we put in services that are Medicaid eligible.
This is for the basic Medicaid. That stuff you're getting into waiver expansions.
Yes.
That's the regular FMAP, called 50-50.
Gotcha.
Because we get added 50-50 for our administrative functions are often 50-50. So when you start going outside of the normal bounds of Medicaid, you're optional and your mandatories, right?
Mm-hmm.
And that's when we're getting into the waiver stuff, which we'll get into in a moment.
Okay.
So we won't get 90-10 on that group. We will get a straight match or we'll get a 50-50 on that group because they're outside the normal boundaries of Medicaid.
So what I'm not quite understanding is what distinguishes these 41,000 people from another 41,000 people? What is their distinguishing?
They're low income childless adults. So they have a certain federal poverty level and they're childless adults. Actually, if you want to weigh in on this.
Yeah, so as I was saying in the previous slide, it used to be that you had to be both low income and categorically eligible. So you had to be a parent, pregnant, age disabled. This new category, you don't have to have that categorical eligibility. All you need is low income. So these are adults that don't fit into any of the other buckets. They're not parents of young children. They're not caregivers. They're not aged. They're not disabled. They're not pregnant. So it's like absent anything else, this is where they fall.
Okay.
So Sorry,
go ahead.
so
and then-
that is for their healthcare.
Right.
Okay.
There's no distinction between childless new adults and any other Medicaid eligibility group in terms of benefit package, besides kids and pregnant women have a different benefit package, but everyone else, new adults, parents, same package.
Go ahead, Representative Bishop.
So if I'm understanding correctly, there's about 151,000 Vermonters whose primary source of health insurance is through Medicaid.
Correct.
41,000 of them are in the childless new adults. The rest qualify both financially and they're in one of these categories.
Correct.
Okay.
And we have a whole bunch of categories that we call Medicaid eligibility groups, MEGs. And for anyone who's really interested, I can send along with the emergency board motion that we sent along. It has the enrollments or the estimated enrollments for all those folks, and that what we use per member per month. But you can see the category. We have general adults, general children, aged, blind, disabled, et cetera. Those are the groups that are sort of identified within our waiver or our agreement with the federal government and how we calculate these costs. So the last point I want to make on this, I'm going to show up, is just, to go to the earlier question, how do we compare to other states? I threw in a list of showing you what the other New England states. Oh, sorry, you want to?
Sure.
Yeah, go ahead.
A follow-up.
Sure.
Can someone be a childless new adult and fit in the other category? And can we elect whether that individual is a childless new adult versus a general? So we get a 9-to-1 match versus $1.43 to $1 match.
Thanks.
So the new adult group, it's a really weedy question. It goes up to a higher income level than the other categories. So if you're a parent caregiver, for example, you're only eligible through that category up to roughly 100% of the federal poverty, and you're eligible up to 138% of federal poverty level under the new adult group. So there are parents of young children who fall into new adults because they're not eligible under that lower income parent category. The pregnant women and disabled categories have higher incomes than new adult. They're at 208 for pregnant women and 225% federal poverty for disability. So those individuals at higher income levels from Social Security checks or whatever else are coming in through that category. So there's some ability to put people in appropriate buckets, but it's mostly dictated by income.
I just want to flag that there is a federal poverty level chart behind chair up there. So anyone who wants to know what 200 or 225% of federal poverty is.
We're going to get a 2025 one.
When it comes out.
And whether the individual falls within the general category or the childless new adults, what the state receives for a match may differ, but the benefits received by the individual are the same.
Correct.
Okay.
And then finally, just to wrap up the FMAP, this is sort of just shows you the history of FMAP. The top chart sort of shows you the blue is the federal, the red is the state share, just over time, just to show you that our FMAP sort of goes up and down over time. On the left side, there's a chart and it shows like years that it's gone up and years that it's gone down. I have the grayed out years where our FMAP decreased, which means our state share increased. And there's so you can see there's sort of like cyclical, where it goes up, it goes down. For 2026, our FMAP's slightly increased. I don't have it in front of me, but on the e-board motion that I referenced, no, actually, that's something different. Forget it. I thought it was going to be helpful. But anyway, the point is it shows you the history of the ups and downs. Now, also on the chart, on the upper chart right, you can see there was a period of time where the federal government gave us enhanced FMAPs for specific reasons. So for instance, under the American Recovery and Reinvestment Act, states were given an additional FMAP for a period of time to help with financial recovery. And then for the Affordable Care Act, we had the Leahy bump, which was, we call it the Leahy bump, because there was a sense that like all these states that aren't doing a whole lot are getting rewarded with these 100% FMAPs. And the states like us that have been doing this stuff all along are like, keep up the good work, And so Leahy was up as the chair of appropriations, was able to get us an additional, I forget it, 1% or something like that, FMAP for like a 3-year period. And that's a lot of money when you have a $1 billion program. So, and then you can see again during COVID, states were struggling again. So the federal government gave us this additional 6.2% over a period of time, which has now ended. So those are what those little dots are. It just kind of shows you just sort of when states are struggling, the federal government, one way they can help states infuse money pretty quickly is by increasing the federal match on the Medicaid program. So during a downturn, our lower income, our more vulnerable, our people with lower, who have compromised health tend to be the people who need the most.
Representative Donahue?
Yeah, it was just, you sort of referenced it, but for newer members, obviously, when you're talking about $8 billion, huge amounts of money, a tiny, tiny change in the FMAP, which we have no control over at all, can have a massive budget impact for that coming year's budget, what's available in state money for other things.
Yeah, to your point, if our FMAP goes down and for the next coming fiscal year, it will cost us up to $8 to $12 million more just to maintain the same level of service. Or, and this year it went up a little bit, well, we have an extra $8 million or $5 to $8 million that provides a little bit of general fund relief. So that, but that all gets captured in the AHS.
I do just want to note also the maybe elephant in the room here is that there are lots of conversations in Congress right now about changing the FMAP percentages for some of these populations. So all of this is like point in time, and we don't really know what's going to happen moving forward.
Yes. Yeah, thank you for that.
Go ahead.
Are there reserves or anything like that in the budget that accommodate this fluctuation?
Yes.
Okay.
In short.
So we're going to move into global commitment, and I'm going to pass the buck back over to Ashley.
All right. So this is where we really get into the uniqueness of Vermont. First, I'll just set the stage with an 1115 waiver. Big number, gets thrown around all the time. The 1115 number comes from the section of the Social Security Act that allows waivers. So that's where it comes from. But essentially, what an 1115 waiver does is allows you to waive some of the laws set forth in the Social Security Act in order to encourage innovation and cost savings within the state program. Many states have 1115 waivers that are specific to certain programs, certain populations, certain sets of services. I think about 47 states right now in the country have 1115 waivers, and CMS approves those in 5-year terms. Durations can be extended. We have had our global commitment 1115 waiver since 2005, most recently renewed in 2022, and then most recently amended this month. The major hook that goes through all 1115 waivers is that they must be budget neutral. So no state can spend more with a waiver than they would have spent without a waiver. And in order to prove that, there is a complicated formula called budget neutrality that people like AHS Finance and JFO will probably talk about at some point during every session. Without a waiver, Medicaid is limited strictly to what is approved in those mandatory and optional services, that chart with the purple and the blue before. And states are not able to get federal match for anything outside of those services. The waiver allows us to do more. Next slide. So as I said, we've had this 1115 waiver since 2005, and essentially it does two major things for us. It gives us funding that we wouldn't otherwise have to pay for certain services, and it gives us flexibility to administer our Medicaid program in a different way. So in the first category of funding, this pays for our waiver-only services, which include the marketplace subsidy, premium assistance for up to 300% of the federal poverty level, our mental health wraparound benefit called community rehabilitation and treatment, which is the only program in the country that provides a comprehensive mental health benefit for individuals above Medicaid incomes, regardless of income limit. We have a V-Farm program, which provides enhanced pharmacy coverage for individuals on Medicare under a certain income level. We have authority to pay for institutions of mental disease, which in Vermont are the Brattleboro Retreat and the Vermont Psychiatric Care Hospital. Without our waiver, we would not be able to use Medicaid dollars to pay for Medicaid stays at either facility. We also provide children's palliative care services. We have a broad category called investments, which we'll do a whole slide on. We are in the process of setting up a wraparound substance use disorder expansion benefit, similar to the mental health one that is already being administered. We just this year are launching the permanent supportive housing benefit, which is for individuals who are homeless, who need pre-tenancy and tenancy supports. And as of this month, we have authority, though we have not yet implemented, the ability to pay up to 6 months of rent and 6 months of medical respite for individuals who are experiencing homelessness. That's the money piece that the waiver gives us. So if our waiver were to vanish tomorrow, we would not be able to do any of these things with federal dollars. On the flexibility side, it sets up our Medicaid program in a very unique way. It allows the Department of Vermont Health Access to serve as a public managed care organization. So in most states in the country, they administer their Medicaid program through private managed care. So in Ohio, they might use 12 different private insurance managed care organizations to deliver their Medicaid program. So in Vermont, what we do is instead of paying a Kaiser Permanente or an Aetna or a United, we're paying the Department of Vermont Health Access to provide those services. And what that does is it allows us to use a more flexible framework, regulatory framework that managed care organizations can take advantage of, but state Medicaid agencies cannot. So this allows us to make payments differently than how CMS would typically regulate a Medicaid program to make payments. It allows us to do value-based payments. It allows us to participate in all payer models and potentially ahead moving forward if that is what the state decides to do. It allows us to administer our home health agencies and designated agencies in the way that we do. And it allows us to pay for payments above and beyond, to set Medicaid payments above and beyond what Medicare sets for certain categories of service.
Go ahead.
So the last bullet point on number one, the as of January 2nd, if I'm understanding it correctly, there was an article in BT Digger as of yesterday or today on this topic, but it made it sound like it's still a long way off, that the Centers for Medicare and Medicaid Services have given some sort of initial approval, but there's a second layer of federal approval, state action that needs to take place. It made it sound like it's still a year or two out. Did I understand that correctly? Is this a multi-layered process with respect to the waiver?
Excuse me, I have not read that bigger article yet. I did know it was dropping, so eager to take a look at that. We have all the federal authority that we need at this time. We cannot implement it until at the earliest January of 2026. And all that the federal authority does for us is says that they will provide federal match. What we don't have is the state match. So that is what I would assume is why it feels phased in that article, is we still have a lot to overcome in terms of identifying state dollars to pay for this, and then actually setting up the infrastructure, the programmatic resources to provide this benefit. So I agree that it's not a short-term solution, but it is a very encouraging piece of flexibility that we've never had before.
To your point, I would say put a pin in this. And when the governor proposes budget and you have it in front of you, you can see if they've actually proposed any general fund.
The article said they're not going to, but I don't know if that's an accurate.
Yeah, well, we'll see when they.
We're quoting administration officials, but I don't, that was,
Yeah.
that's why, when Ashley just said January 26th, I'm thinking like, oh, well, that's FY 26. But that would be.
Just pay attention.
too. Yeah, we should
Particularly do
pay
it.
attention, to what the governor proposes. Rep Steady.
I'm not, well, I have it here. As of 1/2/25, the 6 months of rent, medical respite. Now, the 6 months of rent, how would you correspond with all the other programs that are giving free rent? How would you correspond with them?
Yeah,
Like how,
it's a complicated web for sure.
let's say,
Which is why the design around this is so important, but we're very committed to making sure that we are integrating with the existing voucher programs and other housing initiatives. It's also important to note that this benefit is limited to people who are on Medicaid and eligible for the permanent supportive housing pilot. So this is only available for individuals who are already enrolled in permanent supportive housing, which means that they are experiencing homelessness. I know WCAX, and I haven't read the Digger article yet, but some of the media around this has not really honed in on that point, but the eligibility here is quite limited. It's a great tool for our most vulnerable Medicaid population, but it is not going to be a resource for housing at large.
So in other words, Rep Steady, somebody's not going to be able to receive a benefit in one area and also receive this benefit. That's,
I know that.
okay.
I'm saying, it sounds like you guys gave 10 million extra dollars to that population last year. And that population is most likely on Medicaid. I don't want to be stereotyping, but most likely on Medicaid. And they're already getting the free housing. So it's complicated, like she said.
Yeah.
I mean, I don't want to stereotype, but.
Well, no, and that's not exactly, your statement's not accurate. So, but we can talk offline about that.
Okay.
So we can move through this quickly, but this essentially shows how AHS, the Agency of Human Services, is set up as a single state Medicaid agency and then contracts with the Department of Vermont Health Access. And you'll see these lines going out to the other departments within the Agency of Human Services, because DVA doesn't hold all of the Medicaid program. DVA is the payer, but portions of the Medicaid program are living within the other AHS departments as well.
Yeah, so the point I want to make on this is that when you get the budget, you're going to get this document called the ups and downs. And what this is a document that should show the changes from the base. But what also happens in the budget is a lot of this money is double counted. And that's because it has to be appropriated twice. The money has to be appropriated to the Agency of Human Services. That's where it's matched. And then it goes out to different agencies. So sometimes on a budget, there's lines going across and it says general funds, special funds, federal funds, Medicaid, GCF, that's Global Commitment Fund. So sometimes in like VIVA or Department of Mental Health, you'll see federal and state. And sometimes you'll see GCF, Global Commitment Fund. That means that it was actually matched at AHS and then spending authority through the agency, but it's actually a state federal dollar as well. So I'm just sort of putting the pin in that, just so that you know that when you get the budget, you're like, oh yeah, Nolan talked about how some of this money gets double counted because it has to be appropriated twice. First to the agency and then spending authority for the departments to spend it.
So this slide is really a visual depiction of the first slide that I went through on what the waiver gets us related to the fund sources, the extra money. And you'll see a thin green line around the first half, the top half of this chart, the teal on the top and the purple. Those are things that we will have with or without a waiver. Those are programs that are authorized through the Social Security Act, and we do not need a waiver to pay for any of these populations. Below the purple in the limited benefit waiver groups and waiver only expenditures, we are only able to do this because of our 1115 waiver. And you'll see those are all of the same programs that I mentioned previously. It's just a different way to visualize this, to really separate what we have regardless of waiver and what our waiver provides us. And again, just to state, the waiver right now is it's effective until December 31st, 2027. What that means is we have to renew our waiver, and we will be beginning to work on that next year in 2026, and we'll have to submit our renewal request at the end of 2026. So just to put a fine point on, we're going to be negotiating this waiver in the next couple of years. And this bottom half of the slide is what that negotiation is going to be over.
Okay.
What's the timeline for when we learn whether the waiver is approved? And I'm thinking in the context of the state's fiscal year, if they run up to December of 2027 before we know we're halfway through a fiscal year that we budgeted for months earlier, or do we learn somewhere in the year 2027 about our waiver requests?
So in my opinion, speaking as Ashley and only Ashley, best case scenario here is that we put in our request for an amendment at the end of 2026, and CMS does not have the capacity to negotiate with us and provides us a temporary extension. That is what I hope to see. If that does not occur, then we will likely know fairly soon what the administration is planning with 1115 waivers in more generous Medicaid states like ours. We're in good company in terms of our waiver expiration with California, New York, and Massachusetts all hitting around the same time. And so we will be able to look at our partners there and see what their negotiations are looking like in terms of signaling what our budget situation would be. But honestly, waivers usually get amended like the last days of the calendar year. So it's not something that's going to be finalized certainly before the session ends. You know, we would likely know in December if we didn't get that extension.
Thank you.
And the other thing that it was in the slide above, it was in the here's what our waiver gets us slide, but we have this thing called investments, which is something that is really the envy of every Medicaid program in the country. It sets Vermont Medicaid apart from every other state because we have this ability to pay for things that are not available through traditional Medicaid programs, and they're not available through waivers. And the way we achieve this is through our managed care construct. So going back to that Ohio example, Ohio Medicaid is paying United a per member per month payment to provide services to its Medicaid members. It's $100, we'll say. United only spends $90 on actual medical services, and $10 is profits for their shareholders. That $10 doesn't go back to Ohio Medicaid. It stays at United as profit. In Vermont, that profit is actual savings for us. It's not a profit because we're a state government. But what we can do is reinvest in the Medicaid program. There are stipulations in our waiver that say what we can and can't spend investment dollars on, but they are very, very broad categories, like must help with public health or encourages state-private partnership. You can really drive a train through these categories, and it allows us to spend money and get that federal match on things that otherwise we couldn't and no other state can. It's a really, really cool tool in our 1115 waiver. We have roughly this year about $120 million that we're paying for across 69 different investments. And without this flexibility through our waiver, it would either have to be exclusively state funded or we would be cutting certain investments. The list of investments is at this link here, but it is everything
Oh, it
from.
doesn't, link doesn't work.
Yeah, the link works sometimes and not others. I'm not quite sure why, but I'll send Lori the list.
Okay.
Um,
Just for people, we talked a little bit about this yesterday and understanding Meals on Wheels is one of those things that will be added in 25 to that list.
and a couple other points I want to drive home is we can't be like, great, let's spend on this and this and this. But that's to fit in those categories. And even if it does fit in those categories, we now have to get permission from CMS to actually do it. We also have, there's under an earlier slide, we talked about budget neutrality. Well, there's two neutralities here. One is that's to fit within the neutrality of the total waiver, but we also have caps on how much investments we can spend as well. We can't just let it go. It used to not have a cap, and now we have one.
And we need to come up with the state match money.
Correct.
Yeah. Yeah.
So there are those limitations.
And generally, we need to agree between the legislative and administrative branches on what should be an investment, which is an example of what we did on Meals on Wheels. Yeah.
Meals on Wheels
Again.
was implemented in 2024. That is moving forward. We have it. It's an investment now.
Yeah. Yeah.
We also have investments that are things like providing federal funding to our public health lab, which is a required function of the state, and we are able to put federal resources towards that. That's obviously not like an extra thing that we're doing. We're doing it anyway, but we're using the federal dollars to pull less general fund. We're also paying for things like hospital diversion, emergency department reduction. We have like street workers, street nurses, and other things funded through this. It's a list of 69, so it's really, really broad. Some of them have been in place since the waiver was initiated in 2005, and a lot of them are newer. One of the things that we're working on right now is making sure that these investments can be evaluated, because what we know, particularly with some of the older investments, is that they were just stood up and no one ever asked the question of, is this moving the needle? Is this achieving our goals? Is anyone better off? So we're going back now. We're working with the University of Chicago and really digging in to see what these investments are doing and making sure that we have an evaluation of them, so that if they're working, great, should we scale them up? And if they're not working, should we maybe no longer pay for that investment and reinvest in something else? So that's an effort that we're really just starting on. The NORC contract with the University of Chicago is 5 years, so it's going to be a long process, but we're really excited about digging into these investments and making sure that they're a good use of state funding.
And finally, because we're out of time, here are the federal poverty levels. I tend to stick them at the last slides of these presentations for reference. So the
25 is out, by the way.
What?
25 is out.
Okay, when I made this, it wasn't.
No, I'm just saying. So I just was asking about the update for this.
When I get them, I will continue to chart. Absolutely, I've been paying attention. It just wasn't out when I looked at it.
Yeah, no, I just looked it up.
And okay, great. And so just to summarize, if you've seen one Medicaid program, you've seen one Medicaid program.
Yes, I think it's a good point. Every state's Medicaid program is different. So any last questions for Nolan or Ashley? Thank you. That was actually even more information than I thought we were going to get. So it was good to have that background. And appreciate your time, Ashley, this morning, and yours too, Nolan. I appreciate it very much. And we might see Nolan back in a little while, talking about childcare, clearing up, hopefully, some confusion around childcare.
Try to be helpful.
Yeah. All right. So folks, we are going to move now into continuing our discussion. We didn't sort of make consensus decisions around two teams, our team at Dale and our team at Economic Services and OEO. So we're going to go back to those recommendations, and then after that we'll take a, so it says 10:30. I think we should be able to get through both of those recommendations, and then we'll just have a little bit extra longer time for lunch. Okay, so we won't take a break at 10:30 most likely. Okay, so since Dale went last yesterday, we'll make them first today. How's that? Let's take a look at Dan and Todd's recommendations around Dale. Yeah, go ahead.
So in a nutshell, we're basically saying that the recommend in the BAA should go forward, and that we should really think about how we're going to look in when we look at the 26 budget and when we look at H13, look at how we can make some changes to kind of shore up our systems of support for older Vermonters and not have to keep cycling through EFRs for nursing homes and continued closing of residential care facilities. So really just accepting what's proposed, but then possibly including some language, or at least having that further discussion when we look at H13.
Guys, can I say one thing?
Yes, can we see you? We're taking
Actually, my camera's on the back side. I have no idea what I did.
Oh.
So I'll turn around. You guys tell me when you can see me, okay?
Okay.
Is that okay?
Well, we're there now. We are.
Okay. I have no idea what I did.
Well, I'm not sure either, but go ahead. Go ahead, Todd.
Thank you.
Did you want to make any other comment?
No, I just wanted to tell you that I shouldn't touch anything on this damn thing. I apologize.
Oh, okay. All right.
Thank you.
So what we're looking at is, an overall, it's actually one of the largest chunks in the whole budget adjustment. It's, I think, a total of what, 56 million at Dale? 53 million.
Oh, sorry. 56 total over, in the choices for care is the 53.
Yeah, I thought it was 56. Okay. So $56 million in budget adjustment is attributable to Dale. Again, to summarize, some of it is through the collective bargaining agreement for direct support professionals. I want to point out that collective bargaining agreement has a starting wage of $14.75 an hour.
Yeah, and to add to that, there are bonuses available for individuals who work under 500 hours, is $500. Work over 1,000 hours, you get $1,000.
As long as you're still employed by
Correct.
Over the course of the next year, right? By July of next year?
Yes, which still doesn't add up.
It's
to a
right.
livable
It's
wage
not.
for
Yeah.
hard work.
It is. I'm not sure exactly how to address this, to be perfectly honest, because it is something that it's a collective bargaining agreement. We don't really have, jurisdiction about that. I guess a way we could have an impact in the future is to, potentially set a wage for, people doing direct service work, for long-term care
And
supports and services. We just need to think about it because 1475, frankly, is just, it's not, nobody can live on $14.75. And the fact that we have people doing some very difficult work, assisting individuals to try to live their lives on a day-to-day basis, and that's an agreement. And then what that forces people to do, I realize I'm on my soapbox. Yeah, thank you. I can think of it, but
Nice soapbox.
well, it forces people to receive less service so that they can pay a higher wage to actually keep somebody for some length of time. And that's we're putting the backs on the individuals receiving services and their families, and not in the place where it should be, which is something we will deal with in H13. But I'm also concerned that we're spending 40-something million additional on the highest end of our service system. And we are not raising rates at the lower ends of our support system. And the governor is not recommending anything for residential care homes or enhanced residential care, or people who are receiving supports in another person's home, or any of that kind of stuff. It's only at the highest end. And that's a problem from my perspective. And I think that's what you and Todd were pointing out, that we need to address all residential care in the long-term care system.
yeah, and to get up on that soapbox
Yeah.
with you, how much of the 53 million that we're having to invest in this BAA could be averted if we had paid better wages?
Yeah.
I don't think there's a way to calculate it, but
Right.
it definitely adds to that number.
And we don't have data, frankly, on the 321 people. Is that the right number, Dan? For the residential care homes who have closed. We don't know how many of those 321 people have actually had to then move into higher cost care in nursing homes because we weren't supporting the lower cost care in residential care homes. So it's an ongoing issue. It's an issue that, like I said, we keep referring to H13, but that is a bill that we're starting to take up next week. And it's going to get kind of complicated really quickly, but
And just in rough math, the overutilization works out that 77,000 days works out to 213 beds basically for a year.
Yeah.
So you're right. The question is does that 321 contribute to that 213?
Mhm.
And again, there's no way to really calculate it, but
Yeah.
could it have gone the other way if these beds were available also?
So honestly, our hands are kind of tied on this. We don't really have an option except for, I suppose we could say no to EFR, emergency financial relief, which we actually did last year. We reduced it last year and they restored it in appropriations because that's what they did. It was more of us making a statement about where funds should be directed. So,
Which I think we can continue to do when we take up H13 with some constructive ideas to
yeah.
not have this keep happening.
Yeah. So, thoughts about, or any comments about, Dale? And we didn't really hear anything about developmental services other than the collective bargaining. Do we have any idea about, because they get a substantial amount of money in caseload increase every year? Do we know where they're at in utilization for caseload?
There was nothing.
They're not requesting anything.
No, they're not
so-
requesting anything, but I didn't
know
look
if
into
it's-
that.
Okay.
I'm happy to do so though.
Okay, I'm just curious if they're like, right on, or if they're underspending, or, it's typically something that runs fairly close to the chest. Rebecca's taking care of that. Thank you. Okay, anybody else have any other questions about Dale? I'm seeing a lot of resigned looks of we have to do it. So we will. Am I interpreting the looks or am I interpreting that there's no dissension about this?
What's the dollar figure?
The total amount,
It's $56 million.
is 56 million.
Without the new budget, this is now?
This is for FY 25, the budget we're in right now.
This is to true up the budget for FY 25. It's 56 million,
So how come, I guess, how come this wasn't thought of during the budget process?
Well, I think that's a very good question for half of this money.
At least.
So there is,
At least for the 24 million.
that's right. There's 24 million, related to utilization, which is, 77,000 days.
Correct.
77,000 more days of utilization in nursing facilities than the department budgeted for.
Yeah.
So they misbudgeted, but that's what budgets are. Budgets are estimates, and they're chewing it up to what the actual experience has been. So those are people who are in nursing facility beds who the department is obligated to pay for. They receive Medicaid.
No, I know that.
No, it's because of, a miss on the budgeting, And when we look at 26, we'll be asking about, what levels are you budgeting that at? We want to avoid, big chunks like this. Yeah.
And when you think about it, through the 33 skilled nursing facilities, this is an increase of 200, just over 200 individuals that have gone into nursing home care. That's how expensive this level of care is. So, it's not like, and I'm not sure the exact number of how many individuals are in skilled nursing facilities, but a 200, it's thousands, right? And
I don't know what the number is.
it's 213 basically that will cause a BAA request of 24 million.
Yeah, it's actually could be more than that because that's if they were all
Correct.
there for a full year.
That's if they were all there, but to just kind of
Yeah,
try to put some clarity on it.
perspective on it. Yeah. And I think it's one thing to remember is that we are still in the COVID recovery phase. So we had a lot of people delaying medical care during COVID. Things like, knee replacements, hip replacements, things like that. And that, now are accessing services.
And they require short stays in skilled nursing facilities.
Right. It includes rehabilitative
Correct.
stays.
Yep.
Yeah. So, okay. All right. So, thank you and Todd for your work on that. And, we will move to, OEO and economic services. Back to the discussion that we had yesterday.
So we sent out an updated recommendation doc. You'll see we've kind of combined the topic of GA now that we have more information from the department, and I do want to express my sincere thanks because we had a lot of questions and it was a very heavy lift, and they did a really good.
What time did you send it out?
Just like
10:02.
10 minutes ago, 11 minutes.
Okay.
So hopefully at the top of your inboxes.
There we go. All right.
So you'll remember there was, it was B321, there was $351,627 that they wanted to move out of the kind of regular GA into the general fund for other purposes. I'm not sure what. And then, so our recommendation is that we put that money into the GA emergency housing program. We know it would be like 2.3 million to extend the provisions we kind of have currently right now, extend the winter housing provisions and the current kind of absence of a room cap until June 30th. And that additional total cost for each of those rooms from 4/1 to 6/30 comes out to $5,920. But we also know that we've kind of hit our natural capacity where we're at right now at 1,408 rooms. So our recommendation is we add a little bit of wiggle room just in case, and budget for 1,425 rooms, which would be a total additional cost of $1,924,000. When you subtract that 351,627, it leaves an additional total cost of $1,572,373. That would need to be allocated, total. But that will keep all of these really vulnerable people who are in the hotels right now in the program stable, regardless of whether they've met their 80-day cap. And I do want to say again that these really are the most vulnerable of the most vulnerable. That includes 160 children who will be exited with nowhere to go. There are no other options. There is no shelter. Their option is a tent. If they're lucky, because in September they were running out of those too. Case managers, people were going with their own pockets, and using their own money to ensure people had some sort of shelter. This includes people with extreme mental health diagnosis and struggles. It includes people in wheelchairs, people on oxygen, people who rely on medications that need to be refrigerated to keep them alive and safe. I hope that you will support this.
Okay, Brenda had a question first and then Ann.
Who came up with the date 6:30?
Again, 6:30 is the end of this budget year.
Okay, because camping starts 5:31. And I'm thinking, oh, I'd be jumping in a tent on 5:31. Okay, so I don't agree with this, first of all. And I only agree with the very, very people that are on oxygen. So how would you, the people that are, I saw your face, the people that are very vulnerable. So I do agree with that, but not, I don't want to disable. I don't want to enable perfectly healthy adults. There's some, I did this for 2 years for DCF, so I lived it. I housed the homeless. So how do you, I don't mind the people that are very vulnerable, whatever that word is, but I don't want to enable adults, and I know too much, and I sign confidentiality papers, so I can't really share a lot. But I do agree with the very disabled.
All right, so let's be clear. Okay, I see it, Todd. Let's be clear about the legislature has defined individuals who are vulnerable. Okay, we did that in the budget, and I'm gonna see actually. If somebody can pull it, can you pull up the budget language? I have a
It's on
I have a
my.
hard copy of it right here. I'll have a hard copy of it so I can, so these are people. So last year, the legislature actually determined that the people that you are speaking of are no longer eligible. Okay, they're not eligible for GA,
That particular group.
hotel housing. Okay, so we actually already took care of not housing those people with the limited resources that we have. Okay, so this is right off from the legislation that's already passed. Okay, so I'm just going to read it out loud so everybody understands who is eligible. Okay, so this is to the extent that emergency housing is available and within the funds appropriated, the commissioner of DCF shall ensure that housing is provided in the year that we're in right now to households that attest to a lack of a fixed, regular, and adequate nighttime residence. Okay, so they have to say that they don't have one. And they have the households that have a member who is 65 years of age or older, has a disability that can be documented by receipt of SSI, supplemental security income, or Social Security disability, or is documented on a form that's developed by the department, and they have the means of documenting the disability, or health condition. And then it talks about what needs to be on the form. A medical professional needs to verify that. The medical professional, let me finish.
Oh, I was going to talk.
Oh, I thought you were raising your hand. The raising your hand looked like the same as the other. So
I didn't talk. I raised my hand.
that the medical professional has to document and describe the person's risk posed by their health, safety, or welfare if emergency housing is not authorized. And they have to the healthcare provider has to certify that, including their credentials, et cetera. If the household has a child under 19 years of age or under, or if the household is pregnant, or if the household has experienced the death of a spouse, domestic partner, minor child that caused the household to lose its housing. So sometimes people lose half of their income when they no longer can afford, if they have a death of a spouse, et cetera. Or if they have experienced a natural disaster such as flood, fire, or hurricane, or is under an eviction or constructive eviction due to circumstances over which the household has no control, or if they are experiencing domestic violence, dating violence, sexual assault, stalking, human trafficking, hate violence, or other dangerous, life-threatening conditions that relate to violence against the individual or a household member. So those are the people who are eligible for shelter in a hotel or shelter space.
Just a reminder, we did receive a chart that gave a breakdown, it was a point in time, of how many people fit in each of those, how many households fit in each of those categories who were receiving housing. So just an idea of that.
I was being told the 80 people that had already used their 80 days were going to be extended too. Yeah, that's what I was told. So the people that have already used their 80 days.
Well, I think that
I thought that was included.
Yeah, I want to make sure that they're all.
That's not it, because we don't want to enable them.
What you are recommending is that there is an extension of the winter weather conditions essentially till June 30th. Is that?
Yeah.
Right.
And that means people that have already used their 80 days that could possibly work and whatever.
Yeah, well, I just want to remember that they have to be people who meet those qualifications I just said. I want to go up to Todd because he was waving his hand a couple minutes ago.
Hey, guys, I apologize. I have a huge problem with this motel program. I've done security in Burlington for years. Over half the people shouldn't be there because able-bodied. We're just enabling them, and it breaks my heart. I understand people that are disabled and they have issues. I understand that. But more than half of them should get a damn job. That's all I have to say. Thank you.
Go ahead, Jubilee.
Have you worked in the hotel since this budget and these criteria went into effect? On
Since
July
July 1.
1st of this year, or this past July
We
1st?
should have the hotel people.
Just a second, she's asking a question.
Have either of you,
No, that's not
role
okay.
in DCF for security?
He has.
I've worked for security.
Yeah, he has.
I worked in Colchester. I worked in Rutland at the Econo Lodge, and the one that just closed down. I worked at all the shelters, and I personally witnessed more than half of them. They are able-bodied males that should be out with a damn job, and a lot of them come from out of state. And that's my personal experience. I've been there.
Yeah, no, everybody's entitled to their personal opinion. I wasn't, just a second, please. I just want to ask a question because I'm not sure that I understood your answer, Todd. I understood that you have worked in as security. I didn't understand clearly whether you have done that since July 1. Have you done any security since July 1? I'm just wondering.
July 1, I've done security in Burlington, not at the hotels.
Not at the hotels. Yeah. So I guess what I'm trying to say is that the eligible people changed on July 1, and I'm just going to use your words, the able-bodied men are no longer eligible for the hotel support unless they have a qualifying disability or are 65 or older or any of those things.
Just to clarify though, it's the household that's eligible because of
Yes, it
a
is.
person having that. So anyone who's like seeing and saying, oh, there was an able-bodied person, I just saw them coming out of the hotel. That could have been a household member of a household that met the vulnerability
Yes.
criteria.
Yes.
So just to clarify,
Yeah, that's true.
what one sees, both of what's being said could be accurate.
Yeah.
I guess that's what I'm saying.
Yeah.
And so, well, I'll hold out. That's the brief comment. I had a couple other comments that tie into that, but I'll hold till it turns her.
Okay, Jubilee had her hand up, Ray,
Ray can
and,
go. I'll
and
give
then,
other people a chance to talk.
okay, then, Ray and then Brenda.
Thank you, Madam Chair. I also, and I appreciate like your lived experience working for DCF for 2 years. I appreciate Todd's experience working in hotels. I do want to, and this kind of, I always want to bring this back to our guiding principles and say that oftentimes what you see with your eyes does not match the person's experience and what their circumstances are. So a lot of disabilities are not visibly noticeable. A lot of people who have mental health challenges, you wouldn't know just by looking at them and their physique or their build or, how they present. So I just want all of us to be mindful of that. Is that something that you assume someone is an able body and able to hold down a job may not actually be accurate. And there's a lot of circumstances. And what the legislature did last year, all of us and the whole body, was to really look at, change the eligibility criteria. So we're being mindful and really having a really robust verification system, as Madam Chair just read, by a physician and by benefits that they're receiving, showing that they've already been documented. So if they're receiving these benefits right now, as of July 1, it is because they qualify as a vulnerable population. So just want to kind of emphasize that for us.
Yes, we have Brenda and then we have Jubilee.
So did it change since I worked there? When I worked there, you could call 211 only during the winter exception, and there was no criteria because they couldn't verify it after hours. So anybody could call and say, I'm cold, I just got here from New York, I don't have a bed to sleep in, and they would put them in a hotel because there was nowhere verifying. So can you stop that after hours, and when there's no way to verify it? Can you stop that? Because that was happening a lot.
We're going to hear from 211 as well. So they'll be able to answer that question directly, but they're on our list of people to hear from when we take up the emergency shelter bill. Okay, so we'll hear directly from them to hear what their procedures are.
Before we have to vote on this?
No.
Oh, so you
have to vote.
I wouldn't be able to vote because that was a lot of money.
We'll have to vote on this, but again, the only people who are eligible are those people who have a household that I just spoke of. So a single person who doesn't meet any of these criteria would not be eligible for emergency shelter at a hotel.
I know, but I'm saying after hours, with the winter advisory, they had no way of verifying, so they automatically got a hotel.
And to be honest with you, I don't know what the procedure is for, somebody calls on a weekend and whether or not then on Monday, when the DCF workers are back online, if they then verify it and the person has to leave. I don't know the answer to that question, but we can get the answer to that question.
That would be a nice
Jubilee and then Ann.
And there's no room, so nobody is coming in on the weekend right now because there is no vacancy. Everyone who is there has been verified to be eligible. I do want to get at the household, having a qualifying member. So yes, people may not be disabled themselves, but likely they are providing care for a family member. And I do want to point out, we are spending over 50 million to support our skilled nursing facilities and the like. And we know they have a history of not accepting some of these very same people because of the intensity of their needs. And so that is for some of these people, that is why they have no other option. So just wanted to address also the kind of the whole household aspect.
Yeah, in fact, I just wanted to point out that the state, including Dale and including the legislature, has developed an agreement with a facility in Bennington where they're paying an extra premium, in fact, for those very individuals and people who are people who have medical issues, who essentially their either mental health status, their homelessness status with their medical issues, or their correctional history, no other nursing home will take. And so we're paying upwards of $600 a day for those individuals to be in a nursing facility right now. So I'm just, I think that what you said is a good point.
I keep adding pieces as to this.
Yeah.
So it's getting longer. So one very narrow question. I know that you had updated numbers.
Yeah.
But yesterday, I'm just trying to distinguish. Yesterday, one of the numbers was the 2.36 million to extend.
Yes.
The other was a 50,000 to do more limited.
50,000, it would cost an additional 50,000 to what we originally budgeted to extend the winter weather policy and do away with the 80, that, you know, not ignore the 80-day cap, but have a room cap of 1,100.
I'm for that part. I'm for that part.
And then, thanks, that clarified that. The second thing I wanted to reference is, it's hard to, I'm just trying to get some of the facts out, like, why would some people think I've seen all these able-bodied people? Well, in fact, they may be supporting. But the other piece is, I don't think it's accurate to say, you know, when the time limit hits, all of these people will end up with no option but a tent, if they can even get a tent. Because some of them do have other not good options, not options which fit our definition of adequate shelter, because it's not permanent. It may be, you know, couch surfing. It may be, you know, doubling up with family members. But to say that all of them have no option, but will have no option but a tent, is more extreme than the reality. Some of them will not have an option but a tent. So I just want to balance that out. And actually, you know, I voted against the bill last year, and I voted against it in part because I really struggled with some of the definitions that we constructed in this committee around defining extremely vulnerable. So, and having just talked about extreme examples, I know I'm going to throw out extreme examples. But if you have a family where the eligibility is based on having a 19-year-old child who's not disabled, who's able-bodied, et cetera, the other members of the family are all able to work and so forth, they become defined as one of the most vulnerable, and maybe, you know, taking a hotel room, which then is full, and then somebody who's far more in need can't even access it. So for me, the struggle is the remaining struggle from last year, where I thought that some of our definitions that are in the statute now on vulnerability are too expansive. And that, you know, I don't think it's something we can reconstruct now for budget adjustment, like new definitions. I mean, that's a big piece. But that's one thing that makes me really reticent about putting more money into what I didn't think was a good, the ideal plan. You know, the way my feeling about the whole thing is very different from the way the whole legislature went, because I wouldn't say you have to be highly vulnerable for us to give you a place to lay your head in the bitter cold of winter. I would say anyone who doesn't have a place, we should have a minimum commitment to provide access to a shelter if they want it. But there's a but, and that is some of the things that we've established as, well, we don't want to do this kind of thing because that doesn't have an dignity or privacy or so forth. I mean, there are trade-offs in everything. My own preference, which goes way beyond this discussion, would be to say, you know, we will have basic shelter capacity. In other words, it may be a row of cots in a gym. We will provide for anyone who needs to get out of the cold. But that doesn't mean more expansive supports and so forth. So I think we're putting too much money into a smaller group of people. But that's a much longer, but that's kind of my underlying angst about everything that we've been doing. So it gets very difficult to say, well, I didn't support what we set up last year for all of these larger reasons. And now we're looking at extending it a few months longer. You know, I would be really comfortable with the 50,000. I would be totally comfortable with that. But this level of an expansion, which is what we've kind of been doing for several years now, is like, well, we haven't come up with a solution. Therefore, we're going to keep doing the same thing that we know isn't working or the right way to go. So, you know, I guess I'm still struggling with it, but I'm having a difficult time with, you know, whatever 1.52 million. To not just maintain, but to actually expand what we decided to do last year, we as a legislature, which I didn't support.
That was a lot, Anne.
Well, I said it built up. I had all these notes that built up while the conversation, so.
It's nice talking. I wish I could.
She's had a lot of practice at it, Brenda.
She said everything I think.
Okay, all right. So one of the things that I can't remember if I just asked it in my head and didn't ask you two to, and that's totally possible, but about how much of the $10 million has been spent, the 10 million that was allocated for specific shelter. We were told that the money that's being used for the 2 family shelters was not coming out of that 10 million. And so, did you get any response about that?
Don't know if you asked that. I mean, you can look, I'm pretty, just from updates I've seen, that other, I
Yeah.
believe, has been dispersed through grants. I don't know.
I'm not actually sure that it's all gone out.
Oh,
I
really?
guess that's
Okay, that would be good
that's
to
the
know.
question. It is in there. If we go to our reports webpage, it's reports and resources.
The 11-1 report, is that the one?
There should be one for December 31 housing report. Let me look at the December 31 housing report.
While you're looking, can I?
Yeah.
It said I could go after Am.
Yeah.
I just want to point out that not doing this, like, this money gets spent regardless. We're not saving money by not doing this. It just gets spent and is felt by other ways. These
In
people,
different ways than what, right?
yes. So with, like, not doing this, these people, they go other places, you know? One of the towns I grew up in and represent, it resulted in people camping in the center of our downtown, and that meant more costs that were incurred by our towns. It means that all of those social service providers that I talked about a lot yesterday are going to be serving even more people with the same exact amount of pay and money and resources. It means our emergency departments, our public safety, these costs, our court systems, our juvenile justice systems, housing youth and young adults is prevention. I see what happens when we don't do this in my other job. I've got the data. It's a lot more costly to address it downstream than it is upstream. So we are not saving our state money by not choosing to do this.
So I'm just looking at, I'll get to you just one second. Under the December 31 report, there was $990,757 funding that is unobligated at this point in time. I know that there are things in the works with that money, but it's not been obligated. It's not, they don't have a grant agreement for it.
Repeating that figure, Madam Chair.
990,757. It's in their December 31 housing report that's on our website. And so we will have another report coming out at the end of January, but we have to make this decision before then. So I think that one, if we can find out about that 990, it's almost $1 million. And see what is happening with that. Do you have your hand up, Esme?
Yeah. Yeah, you made some really important points, Rep. Donahue, and got me thinking a lot about just the congregate shelter versus the single family model and just how that impacts different people differently, you know, and having that option. And of course, at the end of the day, people need to be physically safe and like have a place to rest their head. But particularly when it comes down to these visible and or invisible disabilities, I do think that the separation and or ability to have that sort of independent living space can result in different outcomes for sure. I'm just thinking of some examples of like folks I've worked with in the past with like severe anxiety about like being around others and just who had other, in addition to you know, sort of the mental disability piece, very physical ones too that would be impacted by living in that setting. So I do think it is a worthy and different investment of our resources that could otherwise lead to like more ER visits perhaps, or folks who, you know, might not even accept this sheltering, the option of sheltering in a congregate shelter, even though they do need to be sheltered because it's the only option. So I do know some who would.
Just to be fair, I mean, it's not on the table as an.
Oh, totally.
That was like a big term thinking, and it's not real. This decision.
And I think it's also important to note that we do have some recent history with the opening of congregate shelters at the end of winter weather conditions last year, that a handful of people used, frankly. And we spent millions on setting up these shelters that a handful of people used, that we could have continued to house them in the motels.
Well, there's no transportation to them.
Yeah.
I mean, they had other problems.
That's my point. That's my point. Exactly. And so, you know, we have lots of problems that we're not going to solve on budget adjustment. Okay, so I appreciate people sharing their thoughts about this. We're going to have lots of opportunity to debate and discuss this when we take up a shelter bill, which we will be taking up soon as it makes its way to the. I know we have one coming. So as soon as it makes its way up there, we're gonna take it down and we're gonna start working on it. I'm sorry, Dan, I forgot. Yes, go ahead.
No problem. I'm just wondering how many individuals that are meet the criteria. They're in the hotel, they're looking for continuation to the end of the fiscal year. What's their involvement with case management and really looking at how they transition out of a hotel more into whether an apartment or housing, supportive housing? It's a question to find out, like, and then.
Oh,
it's in the report.
They are required in order to remain in their room to be doing case management. We know the current, there is nowhere to move on to.
Right.
And, you know, have to remember last names. It's so.
It's okay. We're just having a discussion.
Yeah. You know, mentioned doubling up. But generally when they're doubling up, they're doubling up with someone they know who has a voucher, and then that person's housing becomes at risk. I've seen people evicted because of that doubling up and not wanting to, you know, it's not a viable option for, you know, that I think we should consider as a true option.
So
But yes, they are all participating in case management as a requirement, and that is checked as part of their.
quality of the case management might be in question,
So-
but, so just a second, Dan, because I really want to focus this on FY 25 budget adjustment, okay? So we are going to have the opportunity to set new policy. We're not going to do it in the FY 25 budget adjustment. So all that we are going to do is to potentially make some, whether we go with this recommendation or some other recommendation, some modification to the current budget that we have before us and what is laid out there. So I really appreciate everybody sharing their points of view, and we are going to have a lot of discussion about that. That is, but I do need to focus back on 25. So I'm going to go back to Dan and then Todd and then Ann.
So, back to the capacity of current case management in the FY 25 budget. Are people getting the case management to a level that will help them move to a more permanent housing? Is the case management sufficient to help people? Do they have access to it?
Depends on who they get it from that's my.
Yeah, and what we're paying. I mean, we get there are hundreds of very wonderful underpaid workers, but they all have
Right.
insane, completely unmanageable caseloads. There's a waiting list. There's nowhere to move into. People are losing their vouchers because they max out the initial time and all of the extensions to find housing. So even you can have the greatest, you could have one person who is assigned to just assist one person. There's not places to move into. It currently takes over a year to go from homelessness just to actually get an opportunity to be housed.
Because I was just looking at within the FY 25 budget, if we're looking at increasing revenue to continue the hotel program, should we be looking at the same time to increase money within FY 25 to increase case management so that they have the capacity to provide and help these individuals? I mean, if we're looking at one, should we be looking at the other one so that we can finally figure out how to get to an end, knowing that there's not the capacity is obviously a pressure that is on. Housing stock pressure is also a problem, but I do see apartments come online. I'm just trying to how do we? No, I don't think anyone really wants to live in a hotel. I think they would rather have some more permanency. And as that stuff becomes available, is there would increase case management and would increase investments in whether it's community action or council on aging, depending on where individuals see their case management, would that help reduce their stay in a hotel?
So it
Just
might.
at the same time.
And we'll talk about that in 26. Yes, Todd. Sorry.
Fair enough.
Todd, go ahead.
Excuse me. Actually, I'll save my statement for another time, like you were saying. That's
Okay.
all I have to say.
And that was Ann.
The chair maybe eventually just clarified the issue for me in terms of the purpose of budget adjustment. This policy, when the legislature passed it, there were a lot of people who didn't support it for various reasons. There were many who did, but it is the policy we enacted, and this proposal is to change the underlying policy that we enacted during budget adjustment. It's not because there's a shortfall to do what we did say we were going to do. And so I think it's the wrong place to make a change in policy like that.
Okay, yeah, go ahead, Doug.
I think the policy was to try to serve a certain number of Vermonters that the legislature deemed was fiscally possible to serve, and an amount was allocated. To me, even if we go above 1,100 person cap, there appears to be at least $351,000 available to serve the purpose of housing vulnerable Vermonters. So I think that would not be missing the mark or changing the underlying policy objectives of the last legislature.
I understand the point you're making, yeah.
Okay.
And, you know, depending upon what of that 990 and that 300,000, we already know the 300,000 is not going to be spent based upon DCF's, you know, including it in the budget adjustment. They didn't include the 990 because I know that they are in negotiations. I don't know, frankly, whether this money will be spent before July 1. I highly doubt it because we are now almost in February and we still don't have an agreement on it. So I depending upon what we hear about that. So we're going to take just a deep breath from this, okay? And Nolan has come back. There has been some confusion around childcare and around the latest economic update report that was that came out yesterday. And because we have one $13 million figure and another $13 million figure, and people are talking about these numbers in different ways. And is it really, you know, are we really bringing, is that $13 million from the revenue, more revenue than we were anticipated, or is just, it's there because we've had less expenditure? All of that kind of stuff is all getting sort of mixed up and gobbled into one. So Nolan agreed to come back. And there is going to be, by the way, a memo that comes out on this at some point in the next day or so from Joint Fiscal Office. But in anticipation of that, and because we have to make our recommendations today, I asked Nolan if he could give us sort of like an overview of what that might contain. And he said he would come back, and he did.
Thank you for doing that, Madam Chair.
Okay.
For the record, Nolan Langwell, the Joint Fiscal Office. I'll try to answer your question the best that I can. So there are several pieces, as the chair discussed. There's the 13.082 million, the caseload savings. Then there's the 13.2 million, which is the CCFAP revenue shift. So the first 13,082,592, that's a caseload reduction. That's just, you know, we were trying to figure out what the caseload would be coming in lower than anticipated. The agency has shown us their estimates, their spreadsheets of how they came up with that. And JFO is okay with it. We don't have any, the assumptions seem sound. We don't have any problem with that. So the second 13 million has to do with the revenue. So the initial revenue estimate was the original estimate was like 81 million. Anyway, long story short, in the budget last year, we estimated, I think it was almost 81.9 million increase. I'm sorry, $81.9 million revenue. Then in July, the economists upped the estimate for the assessment, whatever you want to call it, to almost 93 million. So what they're doing is they're taking that delta of $13 million increase. And by the way, in January, they did not upgrade it again. So the July, this is where there's confusion in the news article. The difference is last year, we assumed one estimate for the revenue. They updated it in July. And in January, they didn't update it again. So that's the $13 million increase in what they estimated to bring in. Now I'm going to put a pin in that, come back. You're seeing, I didn't see the article, but you're hearing about $18 million. That is how much they've collected so far this year. Now it's coming in short because it's in the first quarter. So 18 times 4 is not going to be 96 million, but it's a new revenue. They're estimating there's some compliance issues, and they expect there to be some reconciliation, as according to the economists, that they will still hit their target. So we're still estimating, so the economists still think we're going to hit the target. So the $18 million is confusing because it's what we've collected. It's not a change in what the total will be. That's a complete size. That's just where it's at for the first quarter. So coming back, the 13 million is an increase in the initial target from last year into what the new estimate is. And so since there's more revenue coming in than what was anticipated in the budget, what they're proposing to do is to put that into the CCFAP and then pull out the general fund equivalent, because the fund also includes, not the fund, but the CCFAP appropriation also includes general fund. It was a combination of base general fund, and then when we did the expansion, we raised, you guys raised this new tax to cover the difference. So what's happening is they're bringing in more tax than anticipated from the payroll tax. So what they want to do is swap out that additional equivalent of general fund to free up general fund for other parts of government. The CCFAP appropriation would stay the same. And it's a one-time, so it doesn't change the general fund base. So next year, the general fund that they took out will be back. So it's not a permanent.
So is it really only $13 million and not two, because there's a transfer?
Yeah, so they're trying to think about it because it's so it is confusing. It's my understanding is that it's all one time. I understand. I don't have an answer to that off the top of my head.
Okay.
It's a good question.
I understand that it's all one time.
Yeah.
I realize that the childcare base is not being
Yeah.
impacted. So all you people who are getting letters that, might be coming from advocates sitting around the table here, that say it's childcare is being cut is not accurate. So when you're responding, you can respond in that the base funding is not being cut. And it's very important to remember that this is an entitlement program now, so that if anybody applies and anybody is eligible for services, that obligation must be met. Okay, so you can quell all the fears out there that people are raising. Dan, you had your question.
I think you just answered my question.
Okay,
So when you get the budget, the fiscal year 26 budget, you should see that the general fund should be fully realized. So essentially, it's just a swap. It's a one-time swap.
in essence, I don't think that's going to change our recommendation at all. I mean, our recommendation is to indicate that with any funds, whether it's on the revenue side or the reduction in expenses side, that they stay in CCFAP. And I realize that there's another, that the administration has made a different recommendation, but that they stay in CCFAP and that the initiation of a reserve fund happen. Also, that's something that the state treasurer has recommended that we do, especially given that it's an entitlement program now, which it wasn't prior to last year.
And to your point, if you recall this committee last year, there was a recommendation that because there was a proposal to take money out of the program last year, and ultimately $8 million was put back into the program that wasn't spent. Now, it's not sitting in a reserve, it's just there for the fund, but it's from the payer, I don't remember what it's from, but it's sitting there. That is also still there.
Yeah.
Now, so
That was general fund because the payroll tax didn't start until January.
But there's one small piece that's a little confusing that we're trying to get our head around still. And that there is also a small appropriation that goes to the tax department for implementing all.
Yes, for implementing.
And we're not sure how that affects the ultimate bottom line of all this.
Okay.
We haven't been able to get a clear answer yet as to how much was spent versus appropriated. Does it come out of the 8 million? We're still trying to figure all that out.
Yeah.
But we're hoping to get a balance sheet to be able to answer these questions.
Okay. I think Ann and then Doug and then Son.
You just referenced something which I had not remembered or in terms of what the recommendation was from the work group. From the recommendation, I had understood that the recommendation to create a special reserve fund without a set amount to attach. I didn't know that the recommendation also included saying, and this one time, leave it there. In other words, it would become part of a reserve as opposed to So I'm not clear what the recommendation was as opposed to.
Our team's recommendation did not specify an amount or a
Right.
percentage. So we acknowledge that there is this 13 million that is expenses not incurred.
Right.
And then there's $13 million projected additional revenue. So essentially two $13 million buckets of
From which
funding.
one might, did you say that money had to, were you recommending that stay in those budget lines rather than the recommendation to put them into other things?
We were silent on.
That's what I thought. Okay, so that, right.
Okay, all right, that's helpful.
Yeah, thanks.
Yes, Doug and then Zon.
Your point about the question that remains outstanding on what it may cost the tax department and how that would impact these amounts. Do you have any thoughts or opinion on the fact that the revenue is still projected the same amount, but coming in slower? Is there collections, if you will, for lack of a better word, that is likely to incur greater costs for the tax department to ensure compliance?
Good question. I don't know. I don't think they're anticipating that. It's an interesting question. I hadn't thought about that.
Yeah, I mean, whenever there is something new like this, there's always a period of sort of ramping up. And they do try, I only know this from our local options tax in Waterbury that was passed, where there's been not 100% compliance yet. That the tax department actually, because they can see the sales, they reach out. They can see payroll. They can see whether it's, so they know how and to whom to reach out to ensure compliance with the law. Mostly it's just oversight and people don't realize something has changed.
And also to your point too, if tax department determines that they need more resources, because maybe they're under resourced, whatever, you'd find that in the budget. Because they would propose maybe hiring a new position or eliminating a position, like, as they shake out what their true need is. So to your point about are they under-resourced or over-resourced, that would come out in the budget. Like they would say, okay, we need more people because that's part of why I'm just throwing out an example.
Different part of the budget.
It'll be in the budget.
But that.
In the actual budget.
The actual budget.
They would probably propose it in the 26 budget, say, okay, our experience with the 25 showed us that we need X, Y, and Z.
Gotcha.
And they would propose it there. So that's where you would see that.
And in the implementation of this, they did get resources and they did get positions. So, it's up to them to let us know that that was sufficient or not. So, that was it? Okay. Okay. Yes, go ahead, Brenda.
I'm new. Can you propose both of their proposals?
We're not talking about them right this moment. We're talking about
Oh,
childcare.
Jumped in my head that give the appropriations, both proposals, and let them decide.
So
Okay.
we'll get back to that in a minute. I just want to make sure that, I think that, that's really still clear as mud.
Yeah.
I think the good information is that it doesn't really change our recommendation. So,
That's what I brought from.
yeah.
I got from it too.
And we will look forward to further clarification. I can hear from the speaker's office because there's so many people who are asking questions about this that there will be in the speaker update, I think, when it goes out on Friday, there will be information about this. So watch for more. Yes, Doug?
Can I just state it in a way for clarification to ensure I'm on the right track?
Oh,
That
sure.
The amount of money anticipated to be received is still greater than what was originally budgeted in light of the July forecast. It's just a matter of the timing of when it will come in.
Yes.
That makes more sense.
Yes.
Thank you.
Okay. Alrighty. Thank you very much. Appreciate that.
I think to answer your question about the 13 million, where that money, that's just to bring up general fund again.
Yeah.
So I was trying to get my head around it.
Yeah, got it. Okay, thank you. Okay, all right, now we're going to revert back to our previous discussion, and Brenda actually just had a comment. Why don't you, now that we're back on track, and then we have Ann.
Can you propose both their recommendations? Because I'm for the 50,000, but
We can do whatever we want, honestly.
could we do it that way and let appropriations decide?
They're deciding.
Yeah, so,
No, they're gonna decide anyways, but we could, I think it would be fair to give them both options and let them decide the deciding factor. Does that make sense?
I understand what you're
I'm all new, so I don't know.
right. There's lots of new people, Brenda.
I know, it's so hard being new though.
It is. There's a lot to learn, in a short period of
And
time.
I apologize if I sound,
No, we throw a lot of stuff at people that they have to try to figure out how to understand it in a short period of time. So you don't really need to apologize. It's okay. Ann?
I find Doug's point really well taken about the policy and the money, and that where there is some money, as referenced, that intended to go, that is available because it wasn't spent for these kind of purposes. That's consistent with the existing policy intent and not changing policy. That's obviously a lot smaller. That would be an alternative proposal to transferring new money in that's from an unidentified source coming from somewhere else. And I think that would remain a big difference in terms of changing policy.
Which is why we're trying to find out,
About that,
about
yeah.
this almost $1 million.
I
They're
agree.
working on a response.
Okay.
They are working on a response.
Okay, I'm glad there's going to be a response. I'm very leery about it because if there are things in the works that might before July 1 actually result in new beds, I don't want to impede that progress.
No,
So,
nobody would,
yeah,
nobody
yeah.
would.
So that's good that we'll get an answer.
But I'm pretty sure that will not all be spent. So there may be
Right.
a portion of that.
Right,
that could
which would be
utilized.
terrific. Yeah.
Okay, so I think it's fair to say that let's wait for the response that we get from DCF. What do people think about the first part of the recommendation, which is sorry, I don't have it open, the 350 or whatever it is, thousand that is being unused in the other part of GA, being utilized for emergency shelter. The people in general, it's in the same line items essentially. Okay. All right. So we've come up with that, or not come up with that, but at least reached agreement. We've reached agreement about
Consensus on
that.
that.
Okay.
Just to acknowledge Todd's.
Oh,
Not
Todd
even that.
Todd is not in agreement with that.
Not, okay.
Okay, gotcha. Okay, okay, let's move on to your other recommendations, Jubilee.
Yeah, it's just we plugged in the.
Hey, guys, can I say one thing? I'm sorry for cutting in. Brenda wasn't in the room when you guys did that. I think she should be in the room.
We'll ask her when she comes back.
Okay, I apologize for cutting in.
That's okay, thank you.
You know, the 1.3 million, squares,
Right, that was an.
yeah, that was fine. Then the other one where we needed more data and numbers, was around Reach Up.
Yeah.
So in December, there was a total of 3,732 households receiving Reach Up benefits. 3,277 of those are through the kind of traditional Reach Up program. And then there were 455 households who are in the Reach Ahead program. For those who are new, that is a special program for participants who are working, and it's really designed, it helps them kind of navigate the benefits cliff that often happens. So it becomes less of a cliff and more of a slope, and includes some strategic payouts of money, but it's not a regular monthly benefit like those who are in the traditional Reach Up.
Presented in this committee.
Yes.
When Ann was here originally.
So they are anticipating $499,995 in caseload savings that they would like to move elsewhere. And so we just played around with some scenarios. So one was kind of our original one when we didn't have as much data, was just giving 100 to each household, which will result in some funds that would be left over that could be reallocated or used to help cover any administrative costs that DCF may incur. So you'll see the 100 times the total number of participants would be $300,703. There's little, yes, 200. And that, you see that leaves a pretty considerable, a little over 125,000 remaining. Option 2 would be to disperse the full amount across all households, which rounds out to about $133.97. And then also we could consider only doing it for those who are in the traditional reach up, which results in a payment of about $152.
Okay, thoughts about this proposal? Remember, this is keeping the money in the same place where it is appropriated and for the same population. Brenda?
Being new, my concern is this is only January. How do they know they won't need that 499,000 at some point between now and the fiscal year?
They have a lot of experience in running this program for many, many years, and they have projections. And again, this is a budget. They may be slightly over or slightly under, but they're pretty good at those projections. Yeah, go ahead, Ann.
So, but you're right in the sense that they projected needing a lot more. We're halfway through, the projections could be off again. That's why, to me, I support the idea of we're all being hit with inflation. These folks are particularly hit. But I really like option 1 because that keeps a reasonably significant amount of money for unexpected increase in costs. And so it
doesn't actually.
126.
No, because that's going to the bottom line.
Yeah,
If we don't make a
they'll sweep
recommendation,
that.
it's just going to sweep to the bottom line.
Well, and how we can.
You're right.
They're not going to keep,
They're not going to keep in that
Right.
line for,
Right.
Good point. Thank you.
Unless we recommend.
Yeah, I mean, we could recommend
Yeah.
language that
It
says
says
the
leave
full amount.
the rest
Leave
there.
the rest
Yeah,
there
yeah.
because of
I
unanticipated.
like that.
Yeah, go ahead, Doug.
Returning to a point you made earlier in respect to childcare, that is now the financial assistance is an entitlement.
Yes,
Is Reach Up considered an entitlement? So if there was a shortfall, benefits would still be paid out?
well, there's eligibility. So, I mean, there's criteria to be eligible, but once it's eligible, then yes. Brenda?
Now, yesterday I was all against it, and then I thought about it during the night, because I think about this all the time. I'm thinking I could live with 100.
Yeah.
And with the stipulation, what you said just now, that stay there.
The rest of it stay
Stay
in that
Stay
budget line.
there,
Yeah.
just in case.
Protect
it. So,
And I would just like to, talk, and I'm happy to sit down with you. We have kind of our experiences, and then there's data, and data shows that there is very little fraud. Every study that has ever been done has shown that the amount of fraud in these programs, the cost of doing the study was more than the actual amount of fraud that's happening in these programs.
That hurts a lot of other people because people see the fraud.
Right,
It hurts a lot of people.
It does,
And
because I've seen it.
like, personally, I owe my life to Reach Up and programs like it. I was on Reach Up, I was on food stamps, I had a voucher, and if I had not had those resources, I would not be in this chair today. I very likely would not be alive today, and my daughter's life would be very, very different. So for me personally, when I hear things like that, it's really hard. But I know it's much, much harder for the people in Vermont who are living on these programs right now. So you ever have questions about those things, please, I am happy to talk through them. But also remember that what we're saying right now is being broadcast. Anybody can access it.
it is?
This is public, permanent forever.
Archive.
It's on YouTube.
I mean, I'm fine. I
Yeah.
don't say anything I
So
don't
just
think.
being careful about the things we say and making sure we're being reverent of our words that we're using.
The other thing, I mean, this is the kind of difference, small amount of money to a family that what we're helping prevent is more homelessness, more people
Mhm.
needing emergency shelter because they just couldn't.
So it sounds like there is a consensus around option one with the recommendation that that remaining 126,795 also remain in the program for any potential caseload changes that occur between Todd. So Todd's not swayed by the information we just shared. So he's saying no, but we still have consensus among the majority of the group. Okay. And Brenda, I just want to come back because we did a consensus on all right, at the top of the recommendations from the family, the OEO and economic services, there was $351,627. That's in general assistance. That is that they're projecting to be unused. And the group with the people sitting around the table said yes to moving that to emergency housing. And Todd said no, and he wanted to make sure that you had an opportunity to express your opinion.
And I'm a no.
Right now, the consensus
You
is
said
yes.
it's already in.
Well, the majority voted yes, so.
So the 50,000's out?
No, this is the 351
No.
that's excessed in the budget.
Essentially, what we're trying to find is money that already exists in the budget and actually is already appropriated to this group of people to stay with that group of people.
Can't that come off that?
That's what we're talking about. This
okay.
351, we're saying, let's use that for people who are homeless. Okay?
No, I'm saying the 50,000, can that come off that and we won't have to vote on it? I guess I don't understand. If
Yeah, I understand what you're saying.
51,000 and you're asking for 50,000, why can't it come out of that?
Well, because we have not reached an agreement yet on what we are going to recommend for full emergency housing. We're waiting for more information from the
Oh,
department.
okay, because I was gonna say, why are we even here? Okay.
Okay, all right, thank you. Okay, then we're going down to, I don't think we need anything on the 325. Those are all things that we've already talked about. And then SNAP, I think we all agreed to that one yesterday. It doesn't cost us any more money and it assists individuals, and we lose 29,000 units if we don't use them. Kind of silly. Okay, so we are at a place where we're going to break, unless we have information back yet. Okay, so we have almost all of our work done. Now I have to go to work and put it all together. So you have a little bit of extra long lunch break. We'll be back here at 1, and hopefully we'll have some information back from DCF about that. If we don't, we might leave an open space, or we might have to move ahead without the information. But stay tuned. And Todd, you can go take a break because we're going to go offline.